Professor Kimura, can you present the rest?
The second presentation from Russia, Dr. Averina.
А я не слышу. Могу? Посмотрите. Могу?
We are hearing you, Tatiana.
Yes, we are here.
Thank you.
Hello, everybody. I'm really happy to have a chance to tell you about 20-year MiECC penetration experience in Russia. Here is the map of the Russian Federation, a country with a population of 147 million people. Annually, about 1 million die of cardiovascular diseases. This is the first place in mortality and the second place in morbidity. About 147,000 patients need an open heart operation per year. As you see, in the last 3 decades, the amount of CPB cases has considerably increased. The most productive was the year of 2018, when we totally performed more than 52,000 operations with CPB. The most common pathology was ischemic heart disease with a share of 49%. If at least 5% of them were performed with MiECC, its amount would make up to 1,500 cases. In reality, MiECC penetration is happening very slowly. We conducted a survey according to which about 15 Russian clinics used MiECC during CABG, aortic valve replacement, PCI procedures, and thoracoabdominal aortic constructions. Herewith, all 4 the existing MiECC types were used. Since 2004, about 700 procedures have been made. Among the main reasons for slowly MiECC penetration were a high price, which exceeds much more than twice compared with conventional ECC. In this connection, our clinics could afford to purchase few sets. Due to low frequency use, the perfusionists couldn't overcome the learning curve. Thus, the system seemed to them rather inconvenient and unsafe. Most Russian surgeons tend to prefer operating off pump, considering it to be a real state of art in coronary surgery. Moreover, some other factors mentioned were the change of clinical leadership, COVID-19 consequences, and some supply issues. The first operation with mini-circuit was made on the 1st of March 2004 in the Russian Scientific Surgery Center in Moscow. A 56-year-old woman with ischemic heart disease was operated on by Professor Shabalkin, who used type 1 MiECC circuit produced by Jostra. Professor Lakshin was the first who performed MiECC procedure in Russia. The second group who decided to join MiECC technologies was a team from Surgut, a city in Siberia. In 2006, they performed their first surgery, also using MiECC system with Calafiori cardioplegia. The first MiECC here was conducted by Vadim Tsepenchikov together with Dutch perfusionist Frans Wanders. On the whole, 5 MiECC cases were performed in Surgut and 30 similar procedures using Synergy integrated mini system in Khanty-Mansiysk. The same perfusionist continued his work in the clinical hospital of the President Affairs Management in Moscow. All in all, 134 cases were performed. Their investigation proved that MiECC usage has innumerable advantages. Later, based on these results, a PhD research work was written by Violeta Dvoryanchikova. You will listen to her report at the meeting. Kaliningrad, a federal center, had the richest MiECC expertise, where over 300 operations have been applied. Dynamics of the use is presented in the slide. Bakulev Center is the biggest center of CV surgery in Russia. In the best years, we performed more than 5,000 CPB cases annually. After the visiting of the Bern University Hospital in 2013, we decided to introduce MiECC technologies in our practice. During the visit, we agreed also on a joint study. In 2014, together with Eric Gigatz, we studied microcirculation system in 6 MiECC and 12 conventional ECC cases on the Russian device called a computer capillaroscope. Here you can see this device and its remote management access. The device allows to measure static and dynamic parameters of the regional capillary blood flow, among which a capillary net density, perivascular zone diameter, the size of arterial, venous, and transitional capillary parts, both linear and volume blood flow speeds in real time. We demonstrated that MiECC perfusion provides a steadier blood flow on the micro level, which is resulted in a bigger capillary net density within the perfusion time and at the first day after surgery. Isovolemic perfusion was accompanied by a significant growth of the pericapillary zone. It means oxygen transition distance. However, it remained within normal values. We concluded that in this small group, a MiECC concept showed an evident benefit compared with conventional ECC in terms of microvascular tissue perfusion. After the first interaction with MiECC systems, we understood the need for practical education to be applied in the clinic. To do that, we decided to use an Orpheus perfusion simulator since we highly appreciated it at the first MiECC meeting in Thessaloniki, where it was presented. We developed and introduced an education program devoted to safe MiECC usage. It started in 2015. For a while, we suspended MiECC usage but didn't stop thinking about a new clinical investigation. Such an opportunity came when our surgeons began to practice mini-invasive coronary surgery. To demonstrate the safety of the MiECC system, we conducted an animal experiment. At present, we limited our MiECC practice with mini-invasive coronary surgery, mostly recabbages and thoracoabdominal aortic reconstructions. MiECC makes up 5% of all cabbages and requires CPB under multivessel damages. The MiECC concept implies a combination of the left mini thoracotomy, multivessel bypass surgery, peripheral femoral cannulation under ultrasound guidance, as well as type 3 MiECC usage, isovolemic normothermic flow or supportive perfusion. The combination of both minimal invasive techniques is expected to be a summation of their benefits. We also used semi-closed type 3 mini circuits under thoracoabdominal aorta reconstructions. Compared to a conventional ECC, a semi-closed system provides the best hemodynamic management, makes it possible to perform a quick return of large blood volumes, fulfill more safe mesenteric perfusion, and work under less heparinization. Peripheral ECC connection, venous line, bubble sensor, and autoclamp before centrifugal pump. provides a reliable protection from massive air embolism. Last year, we performed 16 MEC procedures. All the patients passed through an uncomplicated post-operative period and had the minimal stay in ICU and in the clinic. In conclusion, I would like to say that MEC penetration into Russian clinics began 20 years ago. Its development and penetration was associated with direct activities of trauma and Medtronic academies, Bern University Hospital, as well as the extracorporeal circulation section in the All-Russian Association of Cardiovascular Surgeons. The main obstacles to wider penetration were high cost and of consumables and obvious indifference of surgeons and hospital administration. Thank you very much for the listening. I would like to express a special gratitude to the organizers, Kyriakos Anastasiadis, and Politronus Antonitses, who gave me this possibility to take part in this anniversary meeting. Thank you very much.
Dr. Averina, thank you so much for great presentations. We can understand the current situation of development and the penetration of minimally invasive ECC in Russia. It's very interesting and presentation. Thank you so much. May I ask you a quick question?
Yes, of course.
So, are there any available, simulation device in Russia? The simulation device of a MiECC? No. Are you available? Commercial available?
Simulation devices. Yes, we continue to use our simulation program devoted to safe MEC usage. But we don't have enough students, unfortunately, who want to go through this educational program. Because as I have already shown, only 15 Russian clinics had an experience to use MEC within these 20 years. And there are little clinics who wants to join MEC technologies.
Okay, thank you.
Especially we use our Orpheus perfusions.
Right. Thank you, Tatiana. I have to say that we have connection problems with Rajiv Gupta from India and from Alex Cale from the UK. Just to let you know that the intention of us was to try and explore about the situation in countries that are having different setups from the healthcare system and also different environment for adopting MiECC. So before we go into commentators, I would say that United Kingdom is a very fertile environment where MiECC have started with a very dynamic way, though after the COVID situation, it seems that it's stable. And I believe that we will be able to discuss about it to other sessions. About India, India is a developing country, has a great interest. We are discussing a society with a lot of perfusionists like Gupta, who are heading the national societies, and there is a huge interest in India, though India is, with Colombia, I think, the countries that I have really about 98% OPCAB, just because of the consumables. So they are champions in OPCAB use and not using the ECC. So I believe for them it won't be a problem of having an expensive technology or to invest in such kind of technology. And we will go now to commentators, because Russia has been revealed. Russia is a huge country that really has a great potential. Tatiana revealed what are the drawbacks. And also Bern used to be one of the founding countries in this technology. And what I will keep from what Hans-Jörg has said is that they missed their chief, Thierry Carrel, and after that, there have been a lot of, let's say, issues that have been brought up, but most of them we can criticize. But the overall is if you don't have the team and if you don't have the chief, then things will not go this way. So we have with us Lorraine Jansa from Toronto and Mike Van Driel from the industry. Lorraine is a perfusionist and she is working with the MiECC system, so she can tell us some things on the Northern American experience and what's going on, especially in Canada, because United States have started, but it's very low penetration to this country. And of course, Mike Van Driel, Mike is one of the founders of this technology when he was working as an engineer and perfusionist many years in the early decade of 90s. And then throughout the years that he was a leader in the industry, he has a lot to tell us about what's going on in the countries around. And after that, we will have any questions from your side or from us, me and Professor Kimura, who is surgeon from Japan, Saitama, Tokyo. So, Lorraine, the floor for yours. Just give us your talk, your experience of what's going on in Northern America, and especially Canada.